I've tried to capture from the various bits of background that I've got some stuff around data and meds optimization, my limited understanding. I've put big in brackets because actually there's quite a lot of data that we've got. It doesn't necessarily need to be big, could be, but I think it's a word that gets bandied around and sounds very important. So what I want to do is, I want to get the slide to progress, talk about these few things. So it's difficult not to talk about the current environment. I'm going to ask you a question, and I'm going to ask you to type one of three letters into the chat box. So please take part. I'd be interested to hear what you've got to say. And I'm going to break up effectively two parts to my story with some thoughts around policy before I bring everything to a close. I plan to spend about 15 to 20 minutes talking, which might leave a few minutes for reflection afterwards. So you hear an awful lot, and I thought, well, I'm coming to an evidence-based conference, so I should really have some quotes around the fact that loads of people are using um, technology now in the NHS. So I came across a report from the Nuffield Trust, which pretty much sums it up really: rapid adoption, supports remote working, and delivering remote appointments. I mean, super impressive, remarkable work under extraordinary circumstances. And there's also, in parallel to that, been a surge in people like me taking up digital offerings, which perhaps they might not have done previously. So you might guess, because I'm talking a little bit about digital, I was already best part of the way there. But a lot of others have come on board with that. So this has driven some changes in behavior required because of the circumstances. But nevertheless, we've moved. But my impression of this is that the majority of it is kind of transactional. So we can still work, we can still see patients to deliver care. And as Aradazai said in another recent report, there's enormous potential in digital technologies to improve delivery of healthcare. So the orange box in the middle there is kind of a question, isn't it, really? Could there be a bit of an upside that all these things that we've seen and thought about but not really done much with might actually be embedded into practice? And perhaps the subtext for this talk really is this bit at the bottom here. Um, there's a lot of digital tools, and if your experience of working in large organizations is the same as mine, then the majority of the time you'll suddenly see a new widget appear on your laptop or other bit of kit, but not much training, or if it is, it'll be an online thing, and possibly even less thought goes into what can we actually do differently as a result of this new technology? How can we make this better for everybody? Um, which hopefully is the point of new technology, right? So let's think about how we work together to extract the potential benefit. So here's the interactive bit then. So when you've been consulting with patients, so someone like me comes into you, how often has someone told you about a bit of tech that they use to manage their health? So would you say it is A, actually it's never happened to you, no one's ever come to you and said, I really want to talk to you about this because this is really important to me? Is it B, someone actually has done that, but in the context of what you've got to do in a really constrained amount of time, your headspace was, I just haven't got time for this. So let me talk to you about the stuff that's really, really, really need to get through. Or is it the final one, C, which is, okay, that's a bit interesting. Tell me more. Why do you want to talk to me about that? So having turned off the chat box stuff, I don't know whether our chair could just have a look and see if there's any people commented, and if so, what the general feeling is.
So we've got an A, mostly A's at the moment.
Yeah.
Yep,
A's.
A's,
Straight A.
mostly
Yeah.
straight A's.
Yeah. So we're straight A class. Brilliant. That's kind of what I'd expected. I've had experience of both B and C. And I've got to tell you, of the pharmacy conversations that I've had, 100% of them were in C. So well done to the pharmacy profession. It felt very engaging. So let's tell you a bit more about me, my background, and how I got to be here to talk to you. So I live in Scotland, despite the northeast accent. I've been here for nearly 30 years. The two goods in red, I've highlighted because clearly it's judgmental language, shouldn't really use it, but it's a nice shorthand. You'll understand what I mean by that, and it means that the slides don't get messy. So, and it's also I'm reasonably proud of actually being in a good place currently. So, uh, glucose control is fine, and no, and currently both blood pressure and lipid numbers are good. But I want to go back to the start of this. So you'll recognize this picture in front of you. If this came up in a case study, you would immediately start to think of somebody with diabetes, wouldn't you? Tired, thirsty, bit of weight loss. And of course, the icing on the cake is then when you see the HbA1c at 100. That's pretty remarkable. And probably as pharmacists, you're already thinking, okay, what would I do with this character? And you probably do something like this. Yeah, Dave's come in here, he's still walking and talking, nothing dramatic, he's type 2, but we really need to do something quite significant and start straight away on metformin and SU because clearly at this level, diet and exercise is not an experiment we want to undertake. And that's what happened. And I had what I consider a really good primary care team, experienced doctors and nurses, very good clinically, and they worked really hard to get the blood sugar under control. And this box down the bottom has already been mentioned. So my Diabetes My Way is an interactive website which is made available to everybody in Scotland with a diagnosis of diabetes and through which we can access data. But then what happened was I had 2 years of this uh, and I really was tired. Um, I didn't realize quite how grumpy I was until the end of those 2 years. And part of my feeling of being lucky is the fact that A, I'm still married and B, I was still employed gainfully by the same employer. Um, but justifiably, I think in both cases, they could have both told me to sling me hook. The reference on the bottom, the technical term that I've heard bandied around for this is clinical inertia. There's often an extraordinary amount of time for people with type 2 diabetes between escalation of treatments and the also corresponding increase in HbA1c as a result of that. So I'm not alone in this, I don't think. Um, and I don't know how much longer it would have gone on for uh, without this. So each of these red dots represents a point where a test has been taken in preparation for a consultation over a period of about 2.5 years. The big arrow there is the point at which, quite frankly, I just had enough of a circular conversation. And it wasn't that it was appropriate care, but it felt like Groundhog Day. I don't feel well. When's it going to get better? When we'll get your HbA1c under control, we'll increase your dose of metformin, we'll increase your glycoside. That's not working. We'll add in and swap at least two other treatments on that pathway. And of course, there has to be a suitable gap to see the effect on HbA1c. I get all that. So I printed this off and took it into the GP, and the response to that was, "Yeah, it's not working, is it? Um, this needs to change." So this is just data that's already there. We often don't look at it longitudinally like this, but the fact that I could take it out and show it to somebody and the penny drops rather than having the same conversation again is quite significant and hugely helpful. Uh, the place that I live in, Forth Valley, has a very good diabetes team, a good call out to them because they very quickly recognized the fact that I was a latent autoimmune version of diabetes. And given the history, the first thing that they had to do was stick me on insulin. And that was through a full MDT. Interestingly, no pharmacist involved, but pretty much everybody else you could think of, structured education, signed off for a couple of weeks while I got used to carb counting and managing life on insulin, sorting out driving licenses and all that sort of stuff. So really impressed and tremendously helpful. And this is the picture afterwards. So you can see a dramatic resolution and a continued good path. The other joy of seeing the data like this, as for me as an individual, is actually I could see when it started to rise again, and before it got above the kind of recommended thresholds, could start to take steps to bring it back down. The last measure there was the last appointment I had before lockdown, and I currently know I'm still reasonable because I also use Freestyle Libre, and that gives me an estimate and lets me know that that HbA1c estimate is still in the green. And I thought I'll try and stick some meds management stuff in here and meds optimization. So clearly, the first couple of years not optimal. I dread to think what that HbA1c would have got to if I hadn't been taking medicines. At my most draconian, I thought it's a waste of money as a health economist because it's not doing what it should do. In reality, of course, it's done something. but just not exactly what we needed to. So to point at the bleeding obvious, a switch of not optimal to optimal treatment. The other thing, of course, that's interesting in that is the amount of resource that those time periods have consumed. And while 11 appointments in 2 and a bit years is not excessive in some senses, it's significantly more than what's happened since I've been started on insulin. And I guess also an indicator of what meds optimization means. I should also say that during this green line, apparently I'm a lot more pleasant to live with and also feel significantly more energetic. So good outcome all round. So I want to interrupt two slightly different parts to my story with a little delve into policy, and was alluded to this at the outset. And here in Scotland, we have a thing called realistic medicine. The things that I've circled are things around managing risk, personalised approaches, and shared decision making. And of course, in NHS England, we've got, and I've copied this blatantly borrowed from the NHS England website, a comprehensive model of personalised care. And I suspect that if I'd gone to Wales and Ireland, then we would have seen exactly the same sort of models and aspirations. But of course, this sort of stuff's been around for quite a long time, and while we're kind of edging towards it, we're not really there. Um, and I think in this model, you can see five probably of the six boxes there, both data and digital stuff could help with um, directly, if not indeed the sixth as well. And the reason that I put all this up, I think, is that um, I think there's also an imperative to think about what tools could help accelerate this change and how we can support people like me, patients, individuals, probably like a number of you as well, um, to look after ourselves and engage in this process and this discussion about our healthcare. So those who operate in Scotland have probably heard of QI Connect. It's a quality improvement webinar that comes out every month, run by Healthcare Improvement Scotland. Open to the world, and they often start off with a map, which is fascinating. So fully represented globe. And I'd signed up for this one, not being particularly optimistic. It was about data registries in Sweden, and the talk was by a guy from the US. I thought, okay, but it was brilliant. And I've borrowed this slide from him, and he's clearly attributed this to both Dartmouth College and Karolinska Institute. But what you see, I don't know if this will work. Yes, here we go. We've got a little red dot. This bit in the middle here is really where the big data lives, with electronic care records, personal health records, patient facilitated networks, whatever it happens to be. The thing that really worked for me is this bit where it talks about partnership for co-production. Now, I don't know about you, this co-production word I first heard probably about 8 years ago. And it kind of felt like one of those phrases that would be in some sort of lingo bingo game. Not quite sure what it means. Um, kind of think it's probably a good thing. But the penny dropped. Perhaps never been particularly quick with it. Um, but it's all about how can we sit down as individuals and work with healthcare professionals to look after ourselves and optimally. So all of this stuff in some way, shape or form is available in most healthcare systems, and certainly the stuff over here on the right where there will be some clinical records, certainly primary care in pretty much all of the UK, a lot of the trusts, some places it's less so, and of course there's a huge aspiration now everywhere to join up data. I guess we're probably slightly hampered at the moment because there's a little bit of suspicion, certainly in NHS England, as a result of a fairly rushed move to collect all of the data for research, which has now thankfully been paused. However, what this opens up is the potential for thinking about systematic use of big data in the delivery of healthcare, and not just we've got records so we can discuss stuff with you when you get there. So let's move on. The next part of the story I want to talk to you about is cholesterol. So here's a snapshot from 2017. It gives four key metrics in diabetes. And by the way, while I am talking about diabetes, I would invite you either during the talk or after the talk to think about any long-term condition that you deal with. And there are a number of very good digital applications out there to support lots of different things. Um, but you can see that with this target chart, the scores on the doors are not particularly impressive. Yes, the insulin's done its job and my HbA1c was in a good place, but I had significant work to do pretty much everywhere else. And the story that I want to talk to you about and tell you is about cholesterol. And this is what it looks like over time from the first measurements in this diabetes journey. And you can see it's been possibly dangerously high in terms of risk, and something that really I should have paid a little bit more attention to, certainly a lot earlier. Um, I forgive myself the first couple of years because that period of excessive tiredness, and I don't know if you've ever experienced ridiculously high blood glucose, but it really affects how your brain works. Um, but I was convinced, despite the fact that I was ridiculously tired, that diet and exercise would be able to fix it during those early years. Went on insulin, more energetic, and more exercise. Um, in reality, of course, it didn't. And that second red peak there was the point when I looked at this target chart and thought, I've got to accept the advice that I'm being given. I know that statins work and how effective they are and how benign they are. Uh, and that's exactly what happened. So I started on a 12 or 20, and you can see there the line sloped down quite nicely towards what would be a relatively low risk level. But you can also see it's maybe just slightly above an ideal level. And having access to the data then, of course, made me think somewhat. And this second point of further reduction was a point where I got a pharmacist intervention. And the way that it happened was this: I'd looked, having had my bloods tested at the hospital, at the outcome of having taken 12 or 20, wasn't quite happy. So the next time that I requested a repeat prescription, and this is using an app to do it, I typed a little message in that said, I can see me cholesterol is not quite in a good place. Can I please increase the dose of atorvastatin? Sent it off and didn't think any more about it. 2 days later, I got a phone call. And at the end of the phone was one of our practice pharmacists. And the first question was, tell me about this level. Have you spoken to one of the GPs? And of course, I then explained some of the background and the things I've just described to you briefly about my diabetes my way. And hereby lies one of the problems. The practice pharmacist didn't know what this was, possibly hadn't heard that there was a parallel GP system. So, how can you, as practicing pharmacists, find out which digital devices, apps, whatever, are used in your locality? And I'm afraid I don't really have a cunning answer to that. There is an organization called ORCA, which works in a lot of places, and they set themselves up just as a body that would review digital health apps, and they do a really good job. That would give you a list at least of what the top apps are, but it wouldn't necessarily tell you who's using what. So I'm afraid there's a challenge there I'm going to throw across with no solution. But the gist of this is that having typed a message in, the practice pharmacist phoned up, asked all the right questions, said, okay, interesting, went away within an hour. A second phone call that said, spoken to the GP, there'll be a prescription for you for a 12 or 40 in the chemist tomorrow. And of course, what's remarkable about this is it didn't take any of my time to go and make an appointment. It didn't take any of the GP's time to go and sit and listen to me in an appointment just to change something, which was fairly easy. So I was super impressed by the support that I got, the responsiveness, and by the ease of doing it. And again, it's only by using the data and making it available to people in a way that's understandable that these sorts of things can happen. Now, it could be that I'm quite exceptional in some ways and think about this sort of stuff and do things that most people wouldn't. And the reality, of course, is with an average reading age of somewhere around about 9 in the UK, the challenge and digital literacy amongst that, the challenge will be how do we get people signed up for these things? And certainly my experience of signing up for My Diabetes My Way in Scotland was that it took a bit of determination, and rightly so, because what I'm asking to get a hold of is my medical record. So it has to be secure identification of me to make sure it's the right person. There's not many Dave Garrells around, but you can imagine with other names that it might be more of an issue. Uh, so there is an issue there, but it doesn't matter once you get people on board. And I was lucky enough, again, I think Sean Kenny linked me to a couple of things as part of this invitation. But I spoke to a practice pharmacist in Glasgow, and they said, yeah, it takes a bit of support, but the conversations that I have with patients are chalk and cheese. And this is a lady that operates in Mary Hill, which, for those of you who know Glasgow, is one of the more deprived constituencies of that area. So here I am. It's not all a bed of roses. It takes a bit of effort to continue to self care. It's not always smooth, But I think by way of trying to pull all of this together, hopefully where we've got to is that data helps. Data helps people like me. It helps people like me talk to people like you and sit down and come to a good place in my healthcare. And the overwhelming paradigm for such a long time in healthcare is we need to educate people. Once people know what they should do, then they will do it. And that's the bedrock. For me, it's a foundation. Once you know what to do, then you can start to do it. But you need to be moved somewhere else, don't you, really? You need to be somehow activated, as one of these that gets bandied around, motivated, another word. But I guess the nirvana is how many people can we get up at the top here where we're engaging in our own healthcare, we're starting to co-design our care plan, co-producing our own health. And there's that word that I said I didn't like very much, but actually I really understand and probably do like what it means. The reality, of course, is it's not possible to stay up there all the time. And my experience is very much that I'll get there and then for whatever reason, whether it's life, stress, work, something gets in the way and something stops happening. And at this point, that's when I need you to be there, either looking at the data or at the end of the phone for me to either educate or to coerce and get me back on top of the game so that I can continue to not necessarily be in charge, but certainly a co-pilot in my own healthcare. Or as Zoom says, I was a co-host, so I could present this sort of stuff. So a co-host in my own healthcare, perhaps. And that's it. It's a story of how data can help people, how I've been lucky enough to have the data made available to me in a way that makes sense. And even if I wasn't particularly quick in doing some things, it got me there in the end. Also importantly, I think it wasn't everything at the same time. It was probably one thing at a time and then move on to the next. 5 or 6 years in, and the fact that everything's in a good place now, you could see that it wasn't there at certain points. So happy to uh, engage in any discussion now. If you want to get in touch with me at any point, that's my email address. It's 2 R's and 2 L's in Garrell, and it's at gmail.com. And I'm out on Twitter under a slightly odd name, but I had to find out something about a broken train and I had to get on Twitter to find it out. So apologies for the Twitter handle, it's a bit random. Thank you.